Does your skull hiss with every heartbeat? You might hear a rhythmic whooshing sound in your ear, or suffer from a headache that changes intensity the moment you change your body position. These aren't just random pains. They are warning lights for a mechanical failure inside your skull. Your brain does not sit on the bone. It floats in a bath of hydraulic fluid called Cerebrospinal Fluid, or CSF. This fluid acts as a shock absorber. In a perfect system, this fluid is contained, circulated, and slowly reabsorbed. But in patients with a cerebrospinal fluid-venous fistula, a short circuit occurs. A direct, abnormal connection opens between the hydraulic reservoir and the venous drainage pipes. Instead of circulating, your protective fluid is being sucked out of the system and dumped directly into your bloodstream. When the hydraulic pressure creates this vacuum, the symptoms are immediate and physical. The most common is a positional headache, a throbbing pressure that fluctuates depending on whether you are standing up, lying down, or bending over. But the failure spreads beyond pain. You may experience tinnitus, specifically pulsatile tinnitus. This is the sound of turbulence. You are literally hearing the blood flow and pressure changes near your ear because the dampening fluid is compromised. As the system destabilizes, the electrical wiring begins to glitch. You might experience visual disturbances, blurry vision, double vision, or even visual field defects. The low pressure can drag on the cranial nerves, causing nausea, vomiting, and profound fatigue. In severe cases, the brain's processing unit slows down, leading to memory issues, difficulty concentrating, and language deficits. It's a total system drag. Detecting this leak is difficult because the fistula is often microscopic. We cannot rely on guesswork. We use high-fidelity imaging to trace the flow. We start with an MRI with contrast, using magnetic fields to look for signs of brain sag or pressure changes. We may utilize a CT scan with contrast to inspect the bone and fluid channels. However, the gold standard for visualizing the plumbing is the cerebral angiogram. We thread a catheter into the vessels and inject dye, creating a roadmap that highlights exactly where the hydraulic fluid is short-circuiting into the veins. Once identified, we classify the severity of the breach. If the leak is minor and the symptoms are negligible, we may choose observation. This is active monitoring. We watch the gauges to ensure the pressure doesn't drop further and the symptoms don't escalate. For symptomatic cases, we prefer a minimally invasive patch job called embolization. We navigate a catheter to the exact point of the fistula, the site of the puncture. We then deploy a coil or liquid embolic material to plug the hole from the inside. It's like sealing a leak in a tire without removing the wheel. It stops the drainage immediately and restores system pressure. If the fistula is too large, complex, or inaccessible via catheter, we move to surgery. This is a structural repair. We may perform a craniotomy, opening the chassis to access the site directly, or use endoscopic tools to work through a smaller incision. The goal is the same: physically disconnect the abnormal link and seal the hydraulic system. A cerebrospinal fluid-venous fistula is a mechanical breakdown that requires a mechanical fix. If you're hearing your heartbeat in your ear or fighting positional headaches, do not ignore the data. Verify your condition. Use the link in the description to get a second opinion on your imaging.